Welcome to our presentation. This presentation will cover the extracorporeal membrane oxygenation technique, or ECMO for short, and why it is not worth the effort. So ECMO is a specific type of machine that oxygenates a patient's blood outside of their body. This allows for the heart and lungs to rest. The process for which is that the blood flows through a tubing system to the artificial lung, in which the machine adds oxygen and takes out carbon dioxide. While this process is taking place, the blood is warmed up to body temperature and pumped back in.
So in comparison, we already have cardiopulmonary bypass machines, which use a similar process of large tubes placed into your veins and arteries near the heart and lungs. They take out your blood and oxygenate it so your heart does not have to pump anymore. Currently, the heart is stopped using a potassium solution, and it's generally not used outside of heart surgery. It has been used to save victims of heart failure, but often the process does not leave the operating room.
One of the drawbacks of ECMO is the amount of resources that it uses. A one-on-one nurse is required 24 hours a day, and a dedicated ECMO team is necessary to manage the pumps. Because there's already a nursing shortage during the COVID-19 pandemic, and often the nurse-to-patient ratios are double what they were pre-pandemic, many hospitals simply do not have the manpower to use ECMO given the amount of patients that they already have in the ICU. For this reason, we don't think that ECMO is the most efficient way to save victims during the COVID-19 pandemic.
Another drawback of ECMO is that the chances of survival are less than half. Within the centers who started the procedure early on in the pandemic, which is the centers that have already been doing the procedure before with infants, the mortality rates increased to 52% after May of 2020 with the influx of new COVID patients. At the centers that started because of the pandemic, their mortality rate is 58%, and the patients die within 90 days of being placed on the procedure.
Even among patients who do survive being on ECMO, there are some very serious side effects that they need to be aware of. Bleeding is a big side effect due to the medications pumped into a patient's body during ECMO to allow them to tolerate ECMO, and 46% of patients on ECMO experience serious bleeding. Seizures, strokes, and infections are also risks associated with ECMO. 20.2% of patients experience hemorrhaging at the surgical site, and the most common side effect of ECMO is thromboembolism, with almost 77% of patients experiencing this. This is another reason why the dedicated one-on-one nurse is required for ECMO, as they need to manage these side effects and risks that might pop up for these patients.
ECMO is a very cost-heavy procedure. In the US, the cost of the procedure by itself is between $34,000 and $54,000, with the mean being $73,000. The total hospital costs, including pre and post ECMO procedures, are anywhere between $59,000 and $405,000, with the mean being $213,000. Whether the patient survives or not, the family is stuck with this debt, and that can be a huge burden to an already grieving family.
So in summary, we propose that in the context of the COVID-19 pandemic, ECMO should not continue a large-scale rollout. It's too resource hungry for very mixed results. And we propose focusing on ECMO centers that specialize in their use, and we should limit its use outside of these centers until hospitals, technology, and the infrastructure around the procedure improve.